and Dr. Vaishali Vasavada. And we have two fabulous speakers, and looking forward to hearing from both of them. The first talk will be by Dr. Thomas KOHNEN. I think, again, he needs no introduction. Dr. Thomas is from Germany. He's a renowned phaco surgeon who's done a lot of pioneering work, both with the phaco technology as well with the different intraocular lenses. He also happens to be the Arthur Lim Award recipient this year. So congratulations, and looking forward to your talk in Ahmedabad in August this year. So, and he'll be talking to us this morning on his experience with the PanOptix and Vivity IOL. Dr. KOHNEN.
Thank you for the nice introduction, for the nice words. It's a pleasure to be here in India. As you can imagine, just arrived in time last evening from Zurich, going through Frankfurt, and you see my affiliation here. I'm chairman at Frankfurt Department of Ophthalmology. You see also my consultant agreements. We consult for many companies, including Alcon, J&J, Zeiss, producers of intraocular lenses, smaller companies in Europe. I would speak today about PanOptix and Vivity at the symposium. See this disclosure here for medical devices manufactured by Alcon. Presbyopia is really kicking in nowadays. You all know this, more than 1.8 billion people are affected worldwide. This is a publication here. And if you look at the publication, you can see that over the next 10 to 20 years worldwide, there's even an increase. And so this is the University of Frankfurt, the main building, and you can see the patient looking at this has presbyopia. You cannot see the chart. Presbyopia in Germany is also increasing. I just put this slide very quickly. We have the red bar actually at the moment, but we expect over the next 20, 30 years even more presbyopic patients. So it's important for us in Germany, and as I already showed, worldwide. A recent global cataract survey confirms the opportunity to enhance access in presbyopia IOL. You can see that there is a pre-op patient of willing to pay 75%, but only 3% approximately receive, for example, a trifocal lens. So there is a huge opportunity, a huge need. You can say however you want, but you can see that there is also everyday activities are what patients look forward to enjoy most post-cataract, and that is more than 3 in 4 agree that they expect to enjoy more day-to-day activities. So that demonstrates basically that there is a need for these reading activities or using electronic devices. We have to address this as physicians. Just the thinking is, in my country, we still have more than 90% monofocal lenses, but there is a need. People want, they ask me all the time for, can you do something better than a monofocal lens, which my partner, which my neighborhood has? What can I do? So here we put together this slide, which is actually on these two platforms we're talking today, the PanOptix and the Vivity, and you can see that Clarion PanOptix IOL, which we have available now in Europe, in Germany, daily near vision activities, reads frequently, sewing on needlepoint, healthy eye is on this side. On the other side is demand patients' sensitivity to visual disturbances. So in my opinion, somebody who drives at night, is a perfect. And then you have a shared characteristics who difficult to understand sometimes. They can have both in a way. And it's a little bit I think the responsibility of the physician to find that out. It's not, sometimes not easy. Now here's a chart decision tree for Alcon family. And it starts on the right side with patients basically having no need for, let's say, want to have near visual acuity. What I found in the lower part here, always the differentiation between monofocal and toric lenses. Let me summarize what I do. I don't even ask my patients in presbyopia correcting IOLs for toricity anymore. I just correct it. Because if you don't address astigmatism, then the patient is not happy. So for me, it's a question of a monofocal lens, an EDOF lens, or a multifocal lens, and I always address the astigmatism. I think it's just easier. You can go down this line what patients, I come back to this. If you look at the Clarion Panoptics IOL, you have a range of vision, low visual disturbances for a multifocal lens. Spectacle independence is very strong, and improved contrast sensitivity in compared to previous multifocal lenses. Here is the proprietary enlightening optical technology. Important for you to understand is that the near visual acuity is at 40 centimeters, and usually the intermediate would be at 80 if you take a trifocal, normal trifocal IOL. But because of the quadrifocality of this lens, we have now the intermediate focal point as 60 centimeters compared to 80 centimeters. 60 centimeters is what I see here at my computer screen. I had the pleasure to implant actually the worldwide first IOL in Germany. That was, it's almost 10 years now. It's on the 3rd of July 2015. So in July it will be counting 10 years. We did it with a femtosecond laser technology. You see my team here. There were several publications. I tried to summarize them because we want to have a little discussion at the end. This is a clinical outcome after bilateral implantation of the Panoptics with a huge group of numbers and also with physicians. You can see also from India, from the Netherlands, from Japan, United States, Korea, I think, and from India again. So what did we found? These were 6 prospective clinical studies performed across 56 centers, almost 560 patients. And you can see the outcome here in terms of, or let's say the summary of a US study, an Australian, Belgium, so all over the world, and then also from South America. This was all put together. And what is important is this slide. This shows you the defocus curve. If you see these defocus curve, then you can appreciate this is a defocus curve of a young person between 20 and 30 years. Because you see distance, intermediate, and near, and the outcome was a continuous range, and that's important, continuous. When I was doing a lot of bifocal lenses where we had this huge dip for near and for distance, and intermediate you couldn't see, so you were not able to read the computer. Then you can do this with a trifocal. This changed the whole world, in my opinion, in multifocality. And you can see here from very near 33 centimeters to distant 4.4 and 5 millimeter, the peak performance at 66 and 40 centimeters, exactly what we want for these patients. Also, few ocular adverse effects were seen in this study. Not a lot of secondary surgical interventions. Usually that happens if you have a lot of glare, you have a lot of halos, you have a lot of these issues, and people like to complain and you may have to take out. In my opinion, if I do my selection right, I almost never take out a trifocal lens. Never. It's a rare, super rare indication. I would say 1 out of 1,000 maybe that I have to exchange an IOL. And you can see you can see in the publication, if you're interested, what the outcomes were there. Let me go to this. More than 9 out of 10 patients with this IOL reported never need glasses at all distances. That's a really, really strong outcome with this finding, 9 out of 10. And you can see here the Panoptics in 13 studies, 513 eyes, 9 out of 10. That's amazing. It's a really good outcome. Low levels of bothersome visual disturbances was also found, and you can see here 97% of the patient reported no highly bothersome visual disturbances, and 95% of the patient reported no severe. Now, what does it mean? If you ask a patient 1 year after trifocal lens, do you have a halo? They always will say yes, because they have it, because otherwise you have no trifocality and the patient cannot read at 40, at 66. That's the optical principle. We have to understand this, we have to take it away. But the question is, does the patient really bothered by this? If I ask my patients, a year later, you have to ask him for it. They don't come to me and tell me this. You have to ask them. What's important for us in Europe, I think worldwide, in India, maybe in the United States, that we now have the new material. We have it now since actually 2 weeks on all platforms. We have it in the Vivity material. I just started the Vivity the trials were done, but the Clarion material, which is a hydrophobic material, glistening free. These thing here. This is a nice paper which for my colleague, I'm sharing with her the Journal of Cataract Refractive Surgery. See, it shows Associate Editor Liliane Werner from Salt Lake City. This is a study on the haze intensity, and they showed that Clarion material is really one of the best materials if you look at hydrophobic lenses. You can see others also there, but the more you go on the right side, the more you have actually these changes in the material itself. So visual acuity at different distances, range of vision, patient satisfaction, spectacle independence, and refractive outcomes was our trial. We did a panoptic toric trial. Method currently, it was a prospective study at my clinic, single site clinical trial, 3, 6, and 12 months follow-up. 27 patients were included. Interim analysis we can present, and we looked at all these different parameters of visual acuity, the defocus curve, and spectacle independence and satisfaction for the patients. This is a great outcome. Uncorrected, very close in all these areas, far, intermediate 80, 60, and 40 centimeters near, close to 0, 1.0 actually for the near visual acuity, and in the intermediate, close to the distance visual acuity. If you correct, you even get it better. That's how it is. You can go, from distance and to 80 centimeters, 4 meter, 80 centimeters. This is, of course, accumulation. And then you have the 60 and the 40 centimeters, showing you, in general, a very good outcome for these smaller cohort, I have to say, but 27 patients. You still have to examine all of them with the focus curve. This is the focus curve at 3 months post-operative with standard deviation, and very, very, shows the same like we had. This is a previous publication we had done in 2017 with the first series of the panoptics. And then there is the large study of 550 eyes. I put this in one slide together, and you can see that this really much matches all the 3 studies with this super defocus curve for this lens. We also, 90% of the patient reported spectacle independence. As you can see here, 2 need glasses for intermediate vision. That is low number as we found in our study. Interestingly, our contrast sensitivity in comparison to the Acrosoft panoptics was a little bit better in this study, so I have the impression that we get better contrast sensitivity with this. We're not approaching a monofocal aspheric lens, which is a previous study we did in Frankfurt as well, but we are very close to it now. Conclusion, as I pointed, good visual acuity, distance, high patient satisfaction, good contrast sensitivity, and 19 patients out of this perceived optical phenomena, but not they were not bothering by this patient, and they were not concluding about this. So coming back to this selection criteria, because we have not only the multifocal lens, we also have an EDOF lens available, if I'm talking about these 2 platforms. So how do we go this? Let me do this. Extended depth of focus is important. We have EDOF lenses now which are defined by the ISO standard criteria. And I have to speak for Germany and for Europe. There is a burden of IOLs because we have so many intraocular lenses, we don't know which to take sometimes. So we have to follow a little bit the ANSI criteria, and it's a little bit, they are clearly defined for far, for intermediate, for near, what the IOLs should achieve. They should be superior to a control group, negative defocus range at 0.2 logMAR, distance corrected visual acuity at 1 meter, clearly defined what an EDOF lens is. I have the feeling that EDOF lenses are mixed up worldwide. Too many, correlations are done. Vivity, EDOF exceeds the ISO and ANSI standards, which I just summarized, in most of the studies. This is data on file, but of course, Alcon has to register these IOLs, so they have to work in really clear standards, and they have to look at monocular photopic depths of focus, mean monocular photopic, distance corrected intermediate visual acuity at a certain range, then non-inferior to to a monofocal lens, superior versus monofocal lens in the distance corrected intermediate visual acuity, and then the distance corrected visual acuity also. So this has to be fulfilled. A validated questionnaire was used to evaluate the dysphotopsia, which is very important. You can see here, just as an example, no glare and glare, and you can see that the questions were done, the instructions were done, and these are the questions which were taken to the patients. And you see the FDA Command Pro instrument can be used to demonstrate both safety. So it's important to look at this. They were very low in this regard. Now, this comes from a publication we did together, and we looked again at the EDOF. And if I summarize them, you can see that on the right side of this slide, you can see the ISO criteria for non-EDOF lenses. These are the lenses on the right side, starting in the light blue with all monofocal lenses. Then it comes a little bit to indications for presbyo correcting IOLs, but according to the ISO standards, they are not EDOF lenses. They give some presbyopia correction, and we have to clearly tell this to our patient. If you want to be spectacle independent, you have to go into a multifocal lens. If you want to be further spectacle, you go to a real EDOF lens. If you have some intermediate, which is not presbyopia correction, but it's better than monofocal, you go in the middle range, so it's a non-EDOF lens, but works in presbyopia, good for all of us if we have this. Extended depth of focus technology was summarized here. Great paper I think we did together, and there is small aperture, spherical aberration IOL, diffractive and wavefront shaping IOLs. Importantly for me, that you have a non-diffractive lens available. This is the Vivity wavefront shaping technology. I don't want to go into the detail because it extends the depth of focus. And this was also by me studied starting from 2019, where we had the opportunity to do this first in Germany as a first implanter for the Vivity. So that's 6 years ago now. And we published the data in JCRS, Journal of Cataract Refractive Surgery, with our colleagues also. And we found a very nice defocus curve, binocular and monocular. But very importantly, we found a low incidence of halo, 25 compared to 60, 70% with multifocality. So that is the important message we have here. And if you want to achieve a little bit better near visual acuity, we use mini monovision. That's our colleagues from the Netherlands. They have produced this. You slightly aim for the non-dominant eye, half a diopter of myopia, and the dominant eye for emmetropia, and then you can increase the near visual acuity even. We did the same study with colleagues from Italy and found exactly the same, that mini monovision improves our outcome in terms of near visual acuity. Take a look at this slide. This looks at the monofocal lens, a halo profile comparison. I'm interested in this topic. I published a couple of articles on this. Monofocal, Vivity, and then the Clarion Panoptics. This is on the bench, but you can see what the halos are. They are not so much different, much less than I know from the studies. Our defocus curve for the EDOF and the multifocal lens clearly show the difference in near for the multifocality. And if I summarize them, the two papers, I always point out that driving at night is a little bit better with a non-diffractive EDOF than with a multifocal lens. But if you want to read newspaper, then you get a better outcome with a multifocal lens. You have to tell this to your patients. Coming almost to the conclusion, I want to share with you my experience over the last 10 years. I only put here femtosecond laser cases, so all premium IOL cases. And when I look at my monofocal spheric lens, they actually went down. If I look to my monofocal aspheric, which is in green, they went, from basically when we started femto, went up. Most recently, they went up again, and the reason is we started with monofocal plus, but we went down with monofocal plus because I couldn't see so much of a difference in comparison to a good aspheric monofocal lens. We will hear to this later. This is my multifocal data, so huge increase from 2015 when I had the first Panoptics implanted, and then in 2019, as I pointed out, came the Vivity on the market. That's the end of 2024. In March 2025, we very much equal. We have 50% Vivity, 50% multifocal lens. That's my, comes from my clinic, and that's how we treat the patients. Conclusion for me, 1.8 billion people are affected by presbyopia worldwide, and in a recent survey, 75% are willing to pay for a lens, and we know this is a co-payment, usually all around the world, more or less, that is likely to eliminate the need for glasses, but only 3% receive trifocal lens. So there is a lot of opportunities we have. Patients' clinical profile and lifestyle factors are important consideration when recommending the presbyopia correcting IOL. The Clarion Panoptics with the preparatory technology and enlightening technology offers full range of vision. That's important. Near, intermediate, and distance, spectacle independence, low visual disturbances, with the majority of patients not bothered, and improved contrast sensitivity in comparison to the previous models. This is confirmed by worldwide pooled data, not only by our center, it has been all over the world. Latest systematic analysis has been done. And finally, if we look at the non-diffractive EDOF lens with the X-Wave technology, which is a true EDOF lens, exceeds the ISO and ANSI criteria, offering extended vision, including functional near. Functional near means you can read, but if you really want to read the fine print, you need a +1 glass sometimes. But in my opinion, the patients are basically spectacle independence for the whole day. 90%, 95%, they don't need any glasses because they can read the computer, they can drive at night, it's very good. With mini monovision, you can improve this even. Majority patients are no optical phenomena or have no optical, which makes this lens suitable for those sensitive to visual disturbances, and that's my differentiation. So I put this slide together, when do I do multifocal lenses? And you heard 50% there, 50% there. If the patient really wants to be spectacle independent and accepts optical phenomena, I go for the left side. If not, I go for the right side, but I tell them, we can do a little mini monovision to improve near visual acuity, but you need maybe occasionally glasses, which is not the worst in the world, but these are the criteria I use. I thank you for your attention and for the invitation to India. Thank you.
Thank you, Dr. KOHNEN. I think that sets the stage.
Well, just to the audience, just try to get yourself into astigmatic corrections because it's so important. You have to start anywhere. If you don't do it now, just go into it, try anything, go to wet labs, go to seminars. Try to start with simple cases, maybe do first a monofocal toric lens, see how good you are, and then address it, while going maybe to a presbyopia correcting IOL, like we do a lot of Vivity as well, non-diffractive EDOF lenses where you can do it, and it becomes even more important if you go to IOLs like multifocal lenses where you really have to address the refractive error and have to make the patient almost ametropic, and you can only achieve that by, first of all, a superb IOL calculation with the new formulas, AI, the new formulas we have now, and on top of this, addressing astigmatism. That's the way to go. Because I also know that many cataract surgeons do not have a good access to eczema surgery, and then they have to leave the patients, and that's maybe one hurdle, that they don't have that, so they have to address, and it's my prediction would be that we go toric, everywhere as we could in 10 years from now.